target for this afternoon's talk is to talk a little bit about some research that we've been doing for quite a number of years at our lab in New Zealand on cough reflex testing. I think the overarching thing that I want to talk about, though, is the importance of using protocols in clinical practice and in implementing new tests and new concepts within the constraints of some degree of protocol. So I'm going to try to address both of those topics, I suppose. When we look at protocols or protocol-driven treatment, we know from the literature that standardization of care following stroke is strongly supported. There's considerable research that documents that in stroke patients, if they're managed with a very clearly developed protocol, those patients have better outcomes in quality and quantity of life. Now, relative to dysphagia, there are any number of nurse dysphagia screening protocols. And I guess I said nurse dysphagia because in my part of the world that's how it's done. But a dysphagia screening where perhaps all stroke patients are screened for swallowing impairment shortly after admission. And our data support improvement in patient outcomes when those patients are very carefully screened. That presumably it helps us not miss patients that we might otherwise miss, and that those patients get appropriate treatment. However, once we get to swallowing assessment, we have very, very little data on the implementation of protocols into swallowing assessment. There is something that's known as the free water protocol that many of you who work in swallowing might have heard about. And the free water protocol is a set protocol. The data on that are pretty inconsistent in terms of outcome, whether that's actually a benefit to patients or not. Now, when we look at swallowing practice, of course, our big clinical conundrum, do you know what that word is in Greek? I love that word in English, conundrum. It's just a fun sounding word, I think. But our clinical problem in swallowing assessment is this thing called silent aspiration. And if you look at those two X-ray studies, the one on your left, aspirates right there and produces a prompt cough response. It's not effective to clear the airway, but they are producing a cough so that any clinician working with that patient would hear the cough and would have some signal that something wasn't right. Now, the patient on the other side has very similar dysphagia, has food that goes down into the airway, but there's no response to that. And it's that kind of patient that is particularly problematic in our dysphagia management practice. If a patient doesn't let us know that they're in trouble, then it's very hard for us to help them. And all of our early dysphagia screening protocols, one of the problems with those protocols is that they very heavily rely on the patient to have a cough response. But if the patient has sensory deficits, then that's not likely to happen. So this manuscript by Splain-Gard was published a very, very long time ago, probably before many of you in this room were born, actually. And in this manuscript, they did a bedside evaluation or a clinical swallowing assessment, and then they took the patient to X-ray immediately after. And they found that bedside evaluation identified only 42% of the people who aspirated, who got food in their lungs. So they missed 58% of people. And the most problematic point of this study, the very difficult point, is that 70% of the patients who had severe aspiration on the X-ray were not identified as being problematic on bedside evaluation. 70%. It's a huge number when we look at those figures. This study has been replicated over and over and over again. It's a very old study, but the research has been very, very consistently documenting the same effect. Now, if you look at the study underneath that, also quite an old study, but it provides some insight into this, that in the Horner and Massey study, 50% of patients aspirated. There was silent aspiration in somewhere between a third and a half of those. Interestingly, 54% of the aspirators complained of dysphagia, just about half, but 90% of the non-aspirators complained of dysphagia. So here's our problem. If you go into a patient's room and they've had a right cortical stroke, and you say, "How you doing?" And if they say, "Oh, yeah, gosh, things get stuck and I cough in meals and it's really uncomfortable," yeah, they might be dysphagic, but probably not so problematic. The problem is when you go in a patient's room that had right cortical stroke and you say, "How's your swallowing?" And they say, "Fine, I don't have any trouble." Those are the patients we need to be worried about, because those are the patients who have sensory impairment as a component of their stroke. And when you have sensory impairment, all bets are off for trying to understand what's going on in that patient, because we can't see inside. And if they can't give us any external marker of impairment, then we're kind of out of luck. And I think what's interesting, these studies have been around for a very long time, and they've been replicated over and over again. But in clinical practice, we continue to pretend that those data have not been published. Because in our clinical practice, we still go into patients' room, we evaluate them at bedside, we say, "Oh, they didn't cough, must be okay," and then we move on to the next patient. And what we need to get in our heads, and it's a hard thing for us to believe, is that absence of cough does not equal absence of aspiration. It just does not. And in easily a quarter, if not up to 50% of our dysphagic stroke patients, they will not tell us or show us when we're getting in trouble. And of course, the consequence of that is that you can't tell who's at risk and who's not. So you don't implement practices to control aspiration if you don't know that it's there. And then, of course, very importantly, if you have a patient who doesn't elicit a cough response, what goes in the lungs stays in the lungs, because we need a cough to clear out whatever has invaded the pulmonary system. So that's problematic. It's a bit of a double whammy in that regard. Now, a potential solution to this is something called cough reflex testing. It's been described in the literature as well as cough challenge. It involves delivery of a tussive or chemoreactive agent into the upper airway with a recording of a behavioral response. Most frequently, a cough response is what we look for. Now, if you look back at look at those references, cough reflex testing has been around since the 1950s. It is not a new test at all. It's been used in the respiratory medicine research for a very long time on patients with very significant respiratory disease and respiratory illness. If you look back across that history of literature, there have been many, many tussive agents used, 40 to 50 tussive agents used. More recently, the most frequent used are citric acid, which of course is a derivative of orange, of citrus, capsaicin, which is a derivative of pepper, and then tartaric acid tend to be the most frequently used in more recent times.